Welcome, everyone. My name is Dr. Rob Coleman, and on behalf of CME Outfitters, I would like to welcome you to today's educational activity titled Advanced Ovarian Cancer, New Insights on Making the Most of Mutations and Biomarkers to Inform Treatment. Today's program is supported by an educational grant from AstraZeneca Pharmaceuticals and from Merck Sharp Dome Incorporated. Go. Today's activity is brought to you by CME Outfitters, who's an award-winning, jointly accredited provider of continuing education for clinicians worldwide. Now, I'd like to encourage you, everyone, to join us on our live Twitter conversation at CME Outfitters. We will be monitoring the Twitter feed and responding to your tweets as they come in. One last item I want to note is that we are using kind of an enhanced platform today that allows you to save slides, take notes on the slides, answer polling questions, and send us your questions. So you don't need to wait until the end of the show to ask questions. We'll be monitoring for the questions during the program, and we're more than happy to pose them to the faculty during the show. And don't be afraid to challenge them. That's what they're here for. Again, my name is Rob Coleman. I am Senior Vice President and Chief Scientific Officer for U.S. Oncology Research in the Woodlands, Texas. And I'd like to introduce the faculty, whom I believe you probably know well. First, I'd like to introduce Dr. Kathleen Moore, who is the Associate Director of Clinical Research. She is the Director of the Tobacco Settlement Endowment program that funds the Phase 1 Drug Development Unit at the Stevenson's Cancer Center in Oklahoma City at the University of Oklahoma. She also is the Virginia Curley Cade Chair in Developmental Therapeutics and Professor in Gynecologic Oncology. Welcome, Katie. It's nice to see you.
It's so nice to be here.
And then, of course, I'd like to also introduce Dr. David O'Malley, who is a professor in the Department of Obstetric Gynecology, is the division director in the Division of Gynecologic Oncology, and he is the co-director of the GYN Oncology Phase 1 program at the James at the Ohio State University College of Medicine in Columbus. David, welcome.
Oh my God, so excited to be here. I can't tell you how excited I am to be with two of my very best friends and seriously, two of the smartest people I know on this program. Thank you, everybody, for joining. Look forward to a really robust and interactive program.
It's great to have you both here. Thank you. It's good to make it really fun to do. So we have a few learning objectives. I'll just read through these so that you know what we're going to do. Our first objective is to incorporate germline, understand the importance of germline and somatic testing and other biomarker testing that's necessary to inform treatment decision-making in ovarian cancer. We're going to evaluate the recent evidence of mutation of biomarker in connection to treatment efficacy. And we're going to walk through, kind of the natural history of this disease and talk a little bit about the important considerations to make good choices on therapy. A lot of this, of what we're going to present today has been discussed. And so we're kind of hopeful that with this interactive type of environment, we'll get an opportunity to tackle some of the more difficult questions that come up in kind of the real world. And so don't be afraid to ask those questions. Dave's made a promise that he's going to be out there interrogating the entire audience one by one to make sure you guys ask questions. But I just want to make sure you guys feel comfortable to go ahead and put them up into the question section. So this slide here, I think many of you are probably pretty familiar with. You know, when you think about how we come to a treatment decision, there are several factors that we think about, right? Newly diagnosed patient shows up in the office. We are looking at a number of factors and to try to chart the course that's going to be most efficacious for that patient, including when and how we do surgery, how we handle the surgical outcomes with respect to ongoing treatment, how we tackle issues of comorbidities. And then, of course, these other factors that come into play, such as genomic profiling, their stage of disease, and what the ultimate pathology is. All these now become components of the factors that amalgamate essentially to develop a frontline strategy. And many of us are very familiar with this kind of natural history of the disease. You know, we see patients so frequently who come in with months and months of symptoms that are essentially not tagged to the ultimate diagnosis of an ovarian cancer. Many of these patients, as you know, will complain of common symptoms that can be attributed to multiple different ailments, including non-cancer ailments. But ultimately, at some point, people usually end up getting a CAT scan or an ultrasound or something that identifies that something's wrong in the abdomen, and then they do a pelvic exam and determine that maybe this is actually GYN related. Fortunately, it sometimes happens in that sequence. But ultimately, once that diagnosis gets made, we have a plan laid out for potential for surgery, and we have to make that decision about whether or not we're going to do this as a primary event or an interval site reduction. And then we're going to try to plan out the adjuvant therapy. And we have a number of options, which we'll walk through here. We'll basically follow the NCCN guidelines as to how those decisions gets made. And then, of course, we treat during that frontline therapy, and we look for a response. And then at that time of response, we have to make a decision about what do we do next, because we know that there's a high likelihood that patients, even patients who have a complete remission, actually, even patients who have a surgical evaluation for the completeness of their response, still have an extraordinarily high rate of recurrence, maybe as much as 40 to 50% in the setting of a pathologic complete response for recurrence. And so we, at that point, we oftentimes consider a maintenance strategy, and we'll talk a little bit about that. But for those patients that unfortunately do suffer a relapse, the next set of treatments are then outlined by a number of clinical features that would help us to determine whether or not the type of therapy we would use. And fortunately, this is an area of intense investigation as we continue to try to rewrite the standards, not only for recurrent disease, but ultimately for the frontline setting. And we use terms like platinum sensitive and platinum resistant. These, as you'll see, are arbitrary decisions and arbitrary cut points. Nothing magically happens between 5 months and 29 days and 6 months and 1 day. But we do have guidance as to what we think will be the most appropriate therapy in those settings and how that progresses along the way. Now, the story for adjuvant therapy in ovarian cancer has been largely written from an initial study that was published in January 1996, which brought us paclitaxel in the frontline setting. You guys may remember GOG 111 was a seminal paper published by Bill McGuire at that time, and he was responsible for a trial that was essentially substituting paclitaxel for cyclophosphamide. The paclitaxel that was administered in that trial was given over 24 hours, and it was given with cisplatin. And it showed an improvement in progression-free and overall survival. And quickly, the regimen was modified and put into a situation where that could be taken into the outpatient setting. GOG 158 was the trial that confirmed that in a non-inferiority design. And it's been since replicated over and over again. And we did multiple studies, more than 12,000 patients randomized in phase 3 trials trying to figure out a way to improve upon paclitaxel and carboplatin. This trial, ICON 8, actually tried to address another question, which is whether or not dose-dense therapy could improve outcomes over standard Q3 weekly paclitaxel at that time with carboplatin. And you can see here from the results that these three curves, these three arms, dose-dense paclitaxel or dose-dense pac plus dose-dense carbo, was better than standard care. And you can see we really didn't see any difference between those regimens. So we use this as kind of a starting point to try to interrogate how we might be able to add to this backbone of platinum and paclitaxel. And we've had 2 successes along the way that have now kind of changed that upfront standards consideration. And we'll walk you through that. Now, before we get to that, we want to ask you a provocative question. And I'll read it to you. So the question is, following primary treatment with a platinum-based chemotherapy, following chemotherapy resulting in a partial response, in which scenario will HRD testing inform the next steps in therapy decisions? Okay, so this is following primary therapy with a platinum-based chemo regimen, or following platinum-based chemotherapy, and you get a partial response. What further testing will actually inform your decisions with HRD testing? And so you can see here the choices are where BRCA1/2 status is wild type, where there's a known germline BRCA1/2 mutation, where there's a known somatic mutation in BRC1 or 2, when bevacizumab is not used during primary therapy, or E, I'm not sure. So go ahead and vote. Okay, so it looks like about half of the audience basically says they're not sure. This will be good. You can see that that 3% of you actually chose the right response that we were looking for, and that's that where BRCA1/2 status is unknown, or I mean, excuse me, is wild type. So, and we'll go through why that's the case. But Dave, I thought I'd start with you. What do you think about this spread distribution of results?
Well, I think it's really interesting as we look at the way that it was worded was a little confusing, right? In a patient,
yeah, like I read it wrong was the like scenario? 5 times.
Well, I know you kind of stunk at that, but that's a different story. He's like, I'm going to read it to you, and everybody was like, stop reading it to me, man. I'm okay. Anyway, you've been in, and I won't say anything about being in Houston. Anyway, so we have this scenario where you say, okay, when do I want HRD testing? Yeah. And I would argue you want HRD testing and BRCA germline and somatic in every single advanced ovarian cancer patient. But the way that this was written was, when would it really be, when would it tell you something different? Because if they're BRCA positive, somatic or germline, right? Then you don't need the HRD, because they're by definition HRD positive, right? We'll call HRD, right?
Yeah.
So when this helps is if they're wild type, so they're not BRCA mutated or RAD51C or D, you could argue, but we won't get into that quite yet. Okay, so in that scenario, that's when you go, okay, I want more information to really help me decide what my next steps are. And we're going to debate, what those next steps are, and there's lots of different ways to play this, but that is a very important. The way this question was written was a little confusing.
Yeah, Katie, any comments?
Yeah, I think I don't disagree with how it was read being confusing. But just kidding.
Thank you.
I think that one of the things
I'm here all week.
We'll be here we're all night.
Hopefully he just stops reading. Yeah.
I think that one of the things that is key in the question is, when does HRD define the next steps, and when does it not? And so here, and we'll talk about this. So for patients who are in response to therapy, you can use a PARP inhibitor, because that's what we're talking about today, in anyone.
Right.
HRD actually doesn't inform the indication for PARP inhibitor, and I have some thoughts on that. But the label is, it doesn't inform it unless you have started bevacizumab. So if you've started bevacizumab, then HRD, which I use a lot, HRD actually is really important, because you can only layer on the PARP inhibitor per the Paola regimen, and you're going to hear about that in a moment, in HRD positive tumors, inclusive of BRCA. So the only setting in which HRD truly determines can you or can you not use a PARP is in the setting where you have started bevacizumab. And I'm not making an argument, please don't misunderstand me, to not use bevacizumab, because I like that agent.
Yeah.
But that is the setting. We'll talk about those nuances.
Yeah, and that's really key. And I thank you for both in that response. I think that it was tricky, because you're right. You don't need to know this information to actually use a PARP inhibitor. I mean, that's the key. You can use a PARP inhibitor. We'll talk about this. You can use a PARP inhibitor in patients that are HRD status unknown, and as such, a third of those patients will have HRD. So, and what I'm talking about is the biomarker, the BRCA wild type patient population. A third of the remaining patients will have an HRD. So you get it right by not. But if you're a stickler to wanting to use PARP in the biological way, where you think it's going to be efficacious, then you can use that to inform whether or not you're going to use a PARP or not. But I agree with you that if you have not started Bev, it's a decision that you're essentially trying to compare to use nothing or to use something. And I think
can I just argue back to you a little bit? That, and I think we're going to talk about this, but this is a key point that I really like to make, because I've actually learned it a lot, actually, from listening to our partner and friend Brad Monk, is that if you want to be a stickler and get biomarkers to determine when you're going to use a PARP, you have to be a stickler about the clinical biomarkers as well. And the clinical biomarker of response to frontline chemo in settings where you have that information, and you don't have it in everyone, but you do have it in 50% who are getting neoadjuvant. That's probably more important in my mind. And we can argue with that. You can fight me on it. But if you're going to be a stickler, be a stickler for both.
Yeah. And I would say also, you're also placing complete confidence that the test is accurate. And we all know that these tests have both false negatives and false positives. So,
but let me go a little bit different here.
Uh-huh.
Okay. So I think it's a really good point that Katie brings up, but I don't think we need to say being a stickler. I mean, as we look at this, we absolutely have to know, is somebody is BRCA positive, right? So I want to make sure
100%.
we know that. What we have to know that. So you have to do testing. I advocate doing germline and somatic. With the somatic testing, you get the HRD. Let's talk about the people we absolutely should do PARP for. BRCA, we're going to talk about this, solo one, without debate. Prima, without debate, right? You need a PARP. But in the HRD population, if you, again, I believe without debate, you need a PARP. And I know Katie, I think I know what Katie's going to say next. Without debate, you need a PARP and HRD. Some debate in the HR proficient or HRD negative group, or in this case, unknown, as you said, Rob. So for me, I want to make sure identify those patients without debate that I want to use a PARP. And that's why I advocate for the HRD testing as well as the BRCA germline.
Right. And I think a point that absolutely, and I think a point that both of you brought up is essentially is that platinum response, since platinum works in a similar mechanism, not identical, but in a similar mechanism that relies on homologous recombination for repair. If the tumor is deficient in that repair for whatever reason, then they're more likely to respond to platinum.
Right.
And so you can use this as a surrogate. I think that's what she was talking about, clinical biomarker. Is it a surrogate? And we know that the resistance mechanisms are not the same. There are a lot of overlap. But it's something to keep in mind. And that's, I think, a key point. So let me move us along here, because I think, Dave, you said this. You're like, hey, listen, everybody should be tested. Well, all of the major societies agree with you. This has now been put into the guidelines that all of these patients who have this diagnosis should have at a minimum some assessment of their BRCA status. In many parts of the world, this is not universally available. Sometimes it's only the germline testing that can be done because tumor testing is too expensive. But in the United States, it's pretty much attainable. Not only can you get both the germline and the tumor assessment for BRCA, but as Dave mentioned, you can also get HRD testing all in the same sampling. And so that will be, the best annotation that we have today of alterations that we would see that would help us to define that. And again, NCCN, SGO, ASCO, ESMO, all the societies, ESGO as well, agree that this should be the modality. Now, a lot of what we have said today is around the use of PARP inhibitors. And as is usually the case, we do development in patients who have recurrent measurable disease. And so what you're seeing here are the approved, the PARP inhibitors that are approved under the setting of treatment. So patients that come with recurrent disease have cancer that you can see. You give them a PARP inhibitor and the tumors get smaller. So these particular drugs, rucaparib, niraparib, and niraparib, have all had this interrogation done, demonstrating that they can shrink tumors in various different settings. You can see the objective response rates are slightly different because they do represent different patient populations. And the point here isn't really to get into a big discussion about the use of PARP in recurrent disease settings, but that they shrink tumors. Mm-hmm. So the concept here was that, okay, if this agent as a single agent can actually shrink tumors, in this case, that are annotated by a biomarker that is available. So in two of these studies, it was by the attestation of a BRCA mutation. In niraparib as a germline, in rucaparib in the somatic, and in niraparib as the testing for HRD, that they all will shrink tumors in these various different categories. So our next step was then to use that in a way that would allow us to extend the therapy of a platinum-based response. And we called that switch maintenance therapy. And so all three of these drugs were tested in various different studies against best standard of care, which was observation in the platinum sensitive space. So these trials, Solo 2 and Study 19, Ariel 3, and Nova, respectively, for the three drugs that you can see on the slide, were all tested in the setting of patients who have platinum sensitive recurrent disease, were given a platinum-based regimen and responded to it. And then they were randomized to a PARP inhibitor versus placebo. And what they showed, each of these trials showed, was that there was a reduction, a substantial reduction, something we had hardly seen before, a reduction in the recurrence risk in those patients. So progression-free survivals were extended in all three of those studies. So we just took the concept of shrinking tumors that we can see to delaying the progression of tumors we can't see. And actually in Ariel 3, we did a sub-study looking at patients that actually had measurable disease after the completion of platinum-based therapy and demonstrated in the annotated subgroups that they actually shrunk tumors further. So again, the concept of maintenance being moved into the earlier line of sensitive disease. And so this became really relevant, a proof of mechanism that we wanted to tag to our increasing knowledge of what was happening with newly diagnosed ovarian cancers with respect to their genomic profile. And you've seen this slide a lot. Lots of us use it because it's nice to see where the mutation and alterations in the genes that govern the process that we're actually targeting for the use of a PARP inhibitor. And that is the homologous recombination pathway, which is a high fidelity, energy intensive repair pathway that can use the knowledge or the reading of a sister chromatid to provide the missing transcript of one strand of the DNA to provide for accurate repair. When we look at these ovarian cancers, we can see that newly diagnosed patients, that around 15 to 20% of these patients have an alteration in their germline for BRCA. Another 3 to 5% of those patients have an alteration specifically in the tumor itself, but don't carry it in the germline. And then you can see that there are alterations of a number of the governance genes for the homologous recombination pathway. And so because this frequency is so high, it really places a premium on knowing that status. So all three of us have basically agreed that this is so vital to the treatment paradigm for patients with ovarian cancer, because not only can we identify these patients accurately, but we have a therapy that's aligned with it, that has demonstrated efficacy in shrinking tumors in the recurrent setting, delaying progression in the recurrent setting, and ultimately delaying progression in the frontline setting. So having said that, I want to walk you through the current, most recent NCCN guidelines that kind of have now taken all of this information and kind of put it together for us in a way. And I'll walk you through how these decisions got set up and made. So you can see here at the left-hand side, we have a patient with advanced stage ovarian cancer who has standard workup. And so the very first decision, and you heard Dr. Morris mention it, is that she likes to use bevacizumab in these patients. And many of us do believe the data that has come from the two frontline trials that evaluated bevacizumab in the frontline in patients with newly diagnosed ovarian cancer, and those are GOG 218 and ICON 7. So you can see here on this graphic that the GOG 218 was a 3-arm trial, placebo-controlled, where bevacizumab was added to concomitantly with chemotherapy and was in one of the arms, and then was in the third arm was added with chemotherapy and in maintenance. So there wasn't a fourth arm in this trial that was actually studied, but there was, although it was proposed, it was dropped, unfortunately. But you can see that of these 3 arms that there was an improvement in the median PFS for the combination of bevacizumab given during chemotherapy and in the maintenance setting. No difference in the, at least at the medians here in the overall survival, but you can see there was a benefit between 14 months and the control arm, which was the placebo control arm. And ICON 7, not dissimilar, except there was no placebo. It was a shorter duration and different dose of bevacizumab. But the arm that was the comparator arm for the experimental arm was giving bevacizumab during chemotherapy and bevacizumab for maintenance, And it was compared to standard of care at the time, which was paclitaxel carboplatin with just observation. And again, you can see there's an improvement in progression-free survival. And this was both of these arms basically showed statistically significantly different. Now, one thing I always like to highlight with these trials, you can see that the numbers for ICON 7 are generally higher in the two cohorts than they are in 218, both for PFS and overall survival. And this is a reflection of the types of patients that were enrolled in each of these two trials. So most importantly is if you look at the control arm of both studies, you can see there's dramatic difference between the paclitaxel carboplatin placebo arm or the no treatment arm between the two trials. So again, demonstrates the difference in the patient populations. But if you're a believer in this data, you can see that the first checkpoint in this algorithm after the diagnosis is whether or not you add bevacizumab. And the data that would support the bevacizumab, if you're a believer, are based on the what we can see in that study. Now, if you are not a believer in bevacizumab, then you go up to the upper part of this graphic, and the next step that will be interrogated for your treatment decision is whether or not these patients have an alteration in BRCA. Again, so you can see this is why it's important to get this information. Now, the data that would support understanding this this differentiation comes from the fact, as I mentioned before, that the BRCA status in the tumor is going to be critically important to the use of a PARP inhibitor based on the studies that have been done. And you can see in SOLO-1 and in PRIMA, which are both trials that looked at patients who had responded to a platinum-based induction therapy, then randomized to a PARP inhibitor versus placebo. Both of these trials showed a substantial improvement in progression-free survival over control. And so that would be informing that second step in the treatment algorithm. So these are just to give you a sense of what those curves and what they look like. This is the patient population that was annotated by BRCA mutation. And you can see in SOLO-1 the hazard ratio of 0.3, and in PRIMA a hazard ratio of 0.43. Now, again, these do represent different populations in general. They're at-risk populations. But you can see that the treatment effect is consistent between the both of these, representing a 60 to 70% reduction in the hazard for progression at any point of exposure. So again, highly significant and making a lot of difference.
So Rob,
now,
we have some questions coming in. So okay. I think this is a good time. It may be a little premature, but we have some questions coming in. One of which is, and I think this is a good time, we're talking about SOLO-1 versus PRIMA. You know, how long are you going to utilize the PARP inhibitor in a BRCA patient or in any patient you start in the front line? And then, Katie, and talk about what your thought is in platinum sensitive maintenance. And then maybe I can come in if you're going to use it for treatment. We've kind of said we want to use PARP inhibitor for the earlier the better, right? But that's some of the questions coming in are revolving around how long are you going to use it, and do you give them holidays during this time? What do you do? I think this is a good time with the SOLO-1 and the PRIMA up there. Can you talk to how long you're going to be utilizing?
Yeah, so sure, I'd be happy to. For both of these trials, there was a cap on the upper limit of therapy. So in SOLO-1, it was 2 years, and in PRIMA it was 3 years. And I think it was probably a reasonable thing to do since we don't know what the long-term toxicity is in a patient who potentially is cured. And I think that
not many of them.
What?
Not many of them.
Well, let's hope we prove you wrong with your SOLO-1.
No, I mean like at baseline, not many of them.
Yeah,
cured.
That's what I'm saying, right? Yeah. And so, but one of the things that I always point out, and I don't know, again, how valid this is, but you can see that the curves on both of these examples basically become parallel after a certain point in time. And so the question is, if the event rate is the same between the experimental arm and the control arm after a certain point in time, you basically reached the maximal benefit you're going to see with exposure. It's hard to know that. We would have to actually formally test it, but you can see that after about 12 to 15 months in SOLO-1, and basically after about 10 months, 8 to 10 months in PRIMA, the curves are essentially the event rate. The number of patients progressing as a proportion of those that have not progressed is actually about the same. And so the question is, do you get more benefit by just continuing on treatment? Well,
So
we may not. So I don't know.
So Solo 1. So I didn't mean to interrupt you. I apologize. Solo 1
Sorry.
treated for 2 years, Prima treated for 3. What I hear you saying is you're going to make sure that you get at least, if you can, a year and a half of therapy or so.
No,
So
2 years.
So Katie sticks with the 2 years Solo 1, 3 years if she's using Prima and Naraprib. I'm with you, Katie. I stick with what the phase 3 data shows. But I just had a patient this week who said, the fatigue starting to get to me. Usually, once you get through those first few months, the fatigue is stable. But I had that conversation, Rob, that you're just having right now to say, I think we've gotten the maximum benefit. We need to weigh the risk and benefit. I agree with you, Katie. I'm trying to get 2 or 3 years on that. At times, if they need a break, I'm willing to give them a break. In this particular patient, she was at about 18, almost 19 months. We went ahead and decided to discontinue based on just kind of chronic toxicity. But Katie, how about platinum sensitive? We're going to get there, but I think since this question was asked by the audience, it'd be a good thing to talk about a little bit more.
Sure. So can I just comment on frontline? I really would hesitate to put that out there that it's okay to make things up. So the data is 2 years or 3 years. So I really want to be cautious about sort of applying exploratory analyses of these survival curves, to patients until we see overall survival from Solo 1. And that's a very particular population. And we can talk about that a little more. It's very different than Prima, very different clinically.
Right.
And so we can come talk to that. So I just want to make that point. Please don't plan for a year or a year and a half. You're planning for 2. And in a Prima population, I would plan for 3 because that's a very different population that was in Solo. In a platinum sensitive setting, I do treat according to the trials, which is indefinite treatment until progression, because that's really how they were designed. And Solo 2 and Nova and Ariel 3, all looked at this. We've seen overall survival data for 2 of those studies. And in the BRCA associated cancers, it's nominally superior. We can argue about the statistics, but a year is a year. And so it is superior. I'm interested though in this group. And again, I don't act differently, but I am interested in this group because I think as we use more and more maintenance therapies repetitively, we have more of these women who fortunately, I wish they're cured, number one, but a lot of them aren't, and they get platinum and they get a maintenance and they do really well and they get platinum again. So how many of you are seeing 3rd and 4th and even 5th line platinum? Because we're really extending that platinum free interval out. And I am a little bit cautious I'm thinking more about the risk of secondary treatment-related myeloid neoplasms with continuous use of PARP versus the potential overall survival benefit. So I wish I could stop it, to be honest, Dave. Especially Dr. Coleman will hate me for saying this because I have done some secondary side reductions, and my patients with BRCA who had oligometastases, and I resected them and gave them chemo again, and now they're on 2 years of PARP and they're completely NED. And we're even following ctDNA. How about adding that to no evidence? And it's all negative. Gosh, I would like to stop.
Yeah,
but I'm not going to stop unless the patient really wants to. So I think you have to follow the data. But I really want to know, and I'm not sure how to design the trial. I want to know if there's some patients that I don't have to treat for 7 years.
Yeah. Right. And I think that is, I started having that conversation at either 2 or 3 years in that scenario. So many of those patients go in with partial responses and continue to maintain partial responses. If they have a partial response, I continue therapy indefinitely. So the third question, which I asked, which is, how about that patient who came in for some reason, never had somatic or BRCA testing, never had a PARP? Okay. And you discover that and you use PARP for treatment, which one of your earlier slides show. Clearly in that patient population, if they're deriving benefit, I'm going to treat until progression or unacceptable toxicity. So sorry for interrupting you, Rob, but questions were popping in. I thought it would be good to address.
Absolutely. No, I think it's great. And I want to underscore and in bold cap what Katie mentioned about, deviating from the protocols. We do this a lot because in real world, we have patients that don't meet the criteria for our patients, but you can't change the trial. You can't change the way you treat a patient off of the trial and expect that you're going to get the same results of the trial. So you have to stay aligned with that. If you believe the data, you're treating on the basis of it, you really need to follow it until we have better guidance as to what to do. Right. So that very, very good point to bring up. And again, to that same point, we have all these subgroups that are, non-analytical that we're going to be, demonstrating the consistency of effect. I don't want to, again, these were not entirely done with alpha allocated to it, with the exception of the Velia trial here. But Velia, it was a trial, a 3-arm trial modeled very much after GOG 218, its design. So just to substituting veliparib, a PARP inhibitor, for where bevacizumab was. And it basically showed in these patients that had evidence of a HRD tumor, whether it was in the setting of lack of BRCA annotations. These are wild type patients with BRCA who had evidence of HRD. And again, just like we saw in the recurrent setting, where we actually treated patients that were HRD positive, or tumors that were HRD positive, we found that this treatment will shrink tumors. And in these studies, you can see it delayed progression. And then,
Rob, so one of the questions in the chat was, okay, can we use PARP with chemo? So you just said we could. Could you clarify that with what's available in the market right now? I know you did in with Velia, but can we talk a little bit more about that?
Right. So the concept of using chemotherapy with a PARP inhibitor was actually studied in the recurrent setting first. Jonathan Letterman led that trial, and what it was looking at was the use of olaparib with paclitaxel and carboplatin, and they basically showed that it was had a lot of cytotoxicity and required reduction of both platinum and PARP to get through the chemotherapy arm, but did show a difference once chemotherapy was stopped and the PARP was continued. So olaparib was continued on past the finishing of chemotherapy versus patients that just had chemotherapy alone. And so if you looked at that study carefully, you could see there was almost no difference between the two arms, although there were very few events during the chemotherapy, but then showed a split of the curves after they stopped the chemotherapy. Again, basically showing the benefit of maintenance. Well, Velia showed very much the same thing. So we had to use a reduced dose of the PARP inhibitor, of veliparib, which is also not a very strong PARP trapper. So we were able to give this, but we gave it with full dose chemotherapy. And so once these patients completed their chemotherapy, the dose was increased and we used veliparib versus placebo. So it can be given, but it usually has to be given at a compromise of dosing. And I should just note parenthetically that this triplet is in Velia's veliparib is not approved in the United States. So
let me paraphrase for this. That was the longest answer ever to say no. Okay, outside of a clinical trial, do not put PARP with chemotherapy. It's horribly cytotoxic. It's very hard to tolerate. The answer is no. I know you're holding on to Velia. I know you're holding on, buddy, but no, we're not going to try rucaparib, niraparib, olaparib. We're not combining the chemotherapy outside of a clinical trial. Okay, so you can talk. True. You spent 5 minutes to confuse everybody. The answer is no. The answer is
somebody will try it. Somebody will try it. So
exactly. Let me paraphrase. The answer is no. Okay.
I love it. So I agree with you for the first time. And then there were the trials that had, and the reason we're profiling Prima and Velia is that Solo 1 had only patients who had tumors that were annotated by a BRCA mutation. So these are patients that did not fit, were not included in Solo 1. That's why we're showing Velia and Prima. So this is the group of patients that have test negative. And they were defined differently, I should mention. Velia used a different cutoff score for the HRD testing than Prima, but you can see that there is some separation between those curves, but much less than we saw in the HR deficient test negative patients or test positive cases.
This is the case. If you go back 1 second, Rob, I think this is one of the things that we've really learned from this population. And you showed the platinum sensitive studies kind of briefly at the beginning. And I just want to remind folks that the platinum sensitive approvals were obtained in women who had platinum sensitive recurrent disease, got a platinum, responded really, really well,
Mhm.
and then got this. Not the same population as in the bevacizumab studies where you included patients from the beginning of chemotherapy. And so there is not a small proportion of patients who discontinue due to stable disease or progression. And they were all included in those survival or those PFS curves in the platinum sensitive settings. And so that's why that clinical biomarker of response to platinum kind of trumped. I know we're not supposed to use that term, but it's late. The biomarker in the platinum sensitive space, it showed you a gradation of benefit, but it didn't show you a yes, no. And now we come to the front line with PRIMA, which is positive and has the all-comer indication. But again, remember that PRIMA, and I don't know if you're going to show this, Rob, but PRIMA was an incredibly high clinical risk population. 70% of the patients were dispositioned to neoadjuvant chemotherapy. I've never seen that high, a percentage of neoadjuvant on any frontline trial. Even Chorus, which was testing neoadjuvant, only had 50%. So 70%, like almost 40% were stage 4. But despite that, so they're high risk. Despite that, to come on PRIMA, they had to respond really, really well to their platinum. And then they could come on to PRIMA and get niraparib or placebo. So irrespective of what the assay says, HRP, the tumor's already inherent vulnerability.
Some insensitivity, yeah. That's exactly right.
Right, which is why this isn't, to my mind, an all-comers indication. It is still a selected population if you have that clinical biomarker. Now, if you've resected someone, which you should do, please don't take this as an argument for doing neoadjuvant, and they have no gross residual, you have to make your best decision. And of course, I would err on the side of niraparib in that setting. But if you have that information, it tells you a lot. If that tumor has not responded to platinum, they're not going to benefit from a PARP, in my opinion.
That's right. Okay, so that's key. I want to make sure everybody kind of caught that. So what Katie is emphasizing is that in Velia, patients were randomized at diagnosis. So after surgery, they were then put on paclitaxel carboplatinum for their 6 cycles, and then randomized to, and then continued on the randomized arm with a PARP inhibitor or a placebo. Now, if you look at the curve at the top here, you can see at 100% at time 0, those are all the patients who are randomized. And you can see they trend down in both arms during chemotherapy. So these patients are not included in PRIMA. They're not included in Solo 1.
Right.
So these curves are fundamentally different than what was seen in PRIMA. So what Katie said, if you listen carefully, what she said was that it's not an indication for all comers. Okay, so we use that term a lot. If your start point for quote unquote all comers is the completion of chemotherapy, that means in a biomarker unrestricted situation. But if you're talking about all comers like Velia all comers, that's not what was assessed in PRIMA. Those patients responded to treatment. Okay,
go ahead. Finish that thought.
Yeah. So again, so the biomarker here, irrespective of BRCA status and HRD status, is platinum sensitivity and platinum response.
Right.
Key point.
It's a key point.
But it's much harder to tell in the upfront setting. And that's why I really like the HRD, particularly with surgery, interval or primary tumor reductive surgery, because you're artificially improving your platinum response. You have somebody who progresses, you have somebody who doesn't respond. Clearly, that's not a patient who should be going on a PARP inhibitor in my mind. Okay. Now, saying that, what's really interesting, looking at the platinum sensitive, we don't talk that much about this, but we probably need to. So you're hearing us, we're drinking the Kool-Aid, right? We think that maintenance therapy in the upfront setting, absolutely. And you hear many of us use that we use PARP in many different patients. If you didn't use PARP in the upfront setting, and then in the platinum sensitive, they get a very good platinum response, which again, we don't do as much surgery as we used to in those patients. Mm-hmm. You have the clinical biomarker You have the clinical. So in that case, I don't put as much weight in the HRD testing in the recurrent setting. And that I put a lot more in the clinical biomarker of platinum sensitivity, because I'm following those patients from usually a little higher volume disease down. And if you get a complete response, and we'll see some data coming out of some trials, if we get a complete response, they almost behave like a BRCA mutated tumor. Right. I mean, it's amazing.
Bulky disease going down to small volume. Absolutely.
Is a wonderful biomarker, clinical biomarker. So in the recurrent setting, you respond and they didn't get a PARP up front. You got to think that patient needs to get a PARP 100%.
There you go. Okay. I'm going to move us along because we have so much stuff to talk about, and we have great interaction here. So this is really good. And thank you, audience, for sending in the questions. Please continue. We'll get to them. Dave's is monitoring the question area. So moving then on to again, if we have all of our data in front of us, you can see the patients that are who are not started on Bev and are wild type, if they develop a response to that induction therapy, it's just as Dave said, and Katie said, that if these patients are good candidates for consideration of niraparib, it's approved in this indication, or you can observe. And there are people out there who believe that these patients are just as well served to observe. I don't think any of the three of us agree with that, but it's certainly an option. And certainly if patients do not want to go on therapy, that is completely fine. And that would be standard of care, especially if these patients have had a complete response to their induction treatment.
So I have a question from the audience. I want to throw this out for Katie, because I think, so the patient gets a PR, okay, and she's BRCA. I think that we're talking about BRCA, right? She gets a PR, and you start her on a PARP. Are you going to, if that patient doesn't convert to a CR, are you going to continue? How long do you continue? Do you expect to see a response? When would you stop that patient who's coming into treatment on a PR?
Yeah, that's a hard one. Honestly, that's the patient in a BRCA population. We didn't have many of these on solo that came in with PRs. The PRs were really minor, like the CA125 was like 25 instead of 21 kind of thing. So it was a very different population. But we did about 12% of women enrolled on Solo 1 who at the 2-year mark, when they came in, still had some evidence of disease that was being controlled by whatever they were allocated to, PARP or niraparib 2-to-1, and they were allowed to remain on. And so I think I would follow that, to be honest. I would be very, I'm kind of a stickler about 2 years, and I don't really think you should treat forever in the frontline population, especially in a Solo 1 population type, and hopefully we'll talk about that. It's a very different population than Prima. 2 years is enough, except in patients that still have, we've all seen it. The CA125 just never normalizes, or they have peritoneal thickening or some kind of liver capsular thing, and you pet it. I use that as a verb, and it still lights up, but it's not growing. I'm going to hold that patient on PARP, unfortunately, because I don't have better tools. Maybe ctDNA will help us someday. I hope it will. I think this maintenance duration is one of the places where I think ctDNA could actually help us make good decisions for patients in the future, but we need a trial. But I would continue in that particular patient. Very high risk patients who were not enrolled on a lot of these studies, I would continue. But patients who meet study criteria, 2 years is enough. And I stopped.
And the question to me becomes, and I don't think we don't need to address that right now, but at 2 years, if there's still a PR, what do you do? For me, if I have a patient who's a PR in the upfront or platinum sensitive, and I start them on a PARP inhibitor and they are not progressing and clinically they're tolerating it, I continue it indefinitely. We could have the 2 or 3 year debate in the upfront setting, but what else do they have? They're essentially platinum refractory from our previous, definitions, which is a non-CR after primary therapy, right?
It's just hard because we don't have good tools, Dave. Sometimes we call it by a lymph node or these capsular involvement, and it's hard to biopsy, and so you just never know, and you keep treating these women. Who knows if they actually have disease? Right? I'm no magician here in figuring that out. And so
that's a good point. I guess Yeah. And the patient who, I guess the question is that we are convinced, the patient who has some thickening or, the 1.1 centimeter periaortic lymph node, you're not sure what it is.
Yeah.
That's a little, that to me is where the art comes in the discussion on that. But if they're not progressing and they're tolerating it, I would continue until at least the criteria that 2 to 3 years in the upfront setting versus indefinitely in the recurrent.
So before we move on, because I know we're behind, Rob, but the other thing I just want to, because I don't think we're going to talk about this in going through our slides, but the reason we're kind of really thinking about this is a big place of clinical equipoise, because so many patients are not, real world patients are not clinical trial patients. We can all agree that. And you get to the 2-year mark or the 3-year mark on Prima, and you're like, I should just continue indefinitely. And patients sometimes don't want to stop. And what we don't know this. If you don't stop her, are you going to help her? If you don't stop her, are you going to set her up for a more resistant tumor when she recurs? She likely will if you're that worried. And we have early suggestions that the response to subsequent platinum is not as robust in patients who progressed on a PARP, at least, as compared to those who haven't progressed on a PARP, as compared to those who got 2 years apart, stopped for a number of years, hopefully, and then got it. And so what I'm worried about is sort of making decisions because I'm nervous, which we all do. I do. I treat myself half the time, I feel like, because I'm like, let's keep going. But what we don't know is, are we harming her down the line? And that really is what we need to figure out coming forward. So I really think you have to stick in the front line when they have not yet recurred to the study designated time periods, even if it makes you nervous, unless there's evidence of disease that you're controlling, and then you're not maintaining, and you're just maintaining, you're treating her. This isn't maintenance anymore.
Yeah, it's right. You're in treatment phase.
You're treating her. You're just treating her. It's kind of second line almost, but don't call it that because it disqualifies her from other trials. But otherwise, stop until we have some emerging data. PARPs are amazing. Frontline is where you want to use them. 100%. Don't try to save it. Please stop that. Please stop that. But stop at 2 or 3 until we know what impact of forever PARP. I'm a little worried what we're going to see when we see real world data of women being treated for too long.
Yeah. And we had addressed, I know we had to get going, but this is a great topic. We are now looking for clonal effects in marrow to identify patients who are at risk for MDS, AML.
Yeah.
Yeah. So this chip analysis, I think, will help us to potentially identify these patients at high risk and provide some better guidance for duration of treatment. Okay, so let me move on here. The next one is pretty easy. These are patients that are not on Bev who have a germline or somatic mutation and who have responded to treatment. And we've talked this extensively. Both niraparib and olaparib are approved. In the patients in whom you've started on bevacizumab, so we're going to go to the other side of the equation here, and we talked about why you might or might not use it. So the next annotation event here will be whether or not these patients have a BRCA mutation or not, and we've demonstrated the merit of using these 2 drugs, olaparib and niraparib, in patients who have had a response to chemotherapy. Now, this particular cohort of patients have had Bev. And so there are situations where you can stop that therapy and use this. It would still fall under this analytic. But if we take this patient population who is wild type for BRCA and started on Bev, so you got your surgery, you got your chemotherapy and Bev in cycle 2, and it's ongoing, and these patients have had a response, you can annotate this population further with HRD testing. And this is what Dave was talking about earlier on in discussion, where if we find out that these tumors are homologous recombination proficient or test negative, then you can continue the Bev just as you would if you were a believer in bevacizumab based on ICON 7 and GOG 218. However, if they show HR deficiency and are BRCA wild type, you can add olaparib per PALA-1, and this is the data that supported that in the box up here, where this was a randomized trial of comparing paclitaxel carboplatin and bevacizumab with the addition of olaparib or placebo at the completion of chemotherapy, demonstrating non-progression. And you can see there's a significant benefit. This is the patient population for which the intent to treat population was positive, as well as the subgroup that was ultimately led to the approval. Here's the reason for why that happened. In PALA-1, you can see the HRD test positive BRCA patients that were either had a mutation or were wild type. You can see the curves are widely split. The hazard ratios are highly significant, and then at the medians, you can see the differences in there at that midpoint. But in the HRD test negative cohorts, you can see the curves are relatively overlapping. The FDA chose to carve out this patient population, which is why the drug combination has the indication in patients that have HRD test positive tumors. And then the last part of this curve is if you have a patient who you have started bevacizumab and they're identified as having a mutation, those patients would be also eligible because they are by definition HRD. And you can add olaparib, or as I mentioned, you can add olaparib or niraparib. It would also be the case. I personally am not a big fan of stopping bevacizumab, but you can make the case for it since most of the toxicity is actually captured in the chemotherapy combination component of it. But there are other reasons for why you might want to not have an IV therapy. So here's what we walked through. We have the red box is a choice that's been made, so Bev or no Bev. The next two boxes are essentially around the the genomic annotation, so BRCA mutation and then HRD status. And this is how it all fits together. And if you put all the data together, you can see that these molecularly annotated populations show benefit to these drugs. This is the value of a predictive biomarker as opposed to just a prognostic biomarker. In this case, we have a biomarker that actually serves both contexts, but in patients who have the alteration and got the drug, they got a benefit. And all those long bars over their controls basically show those benefits. And I've asterisked on this slide, if you're downloading it, I've asterisked the particular analyses that are analytical. They have alpha associated with their analysis. So you can look at that more carefully in your spare time.
Yep.
Okay, so let's go to the last question for this section before we transition over to Dr. Moore. Okay, now, how closely will you try to adhere to the NCCN frontline treatment guideline algorithm for ovarian cancer? Very loosely, somewhat closely, very closely, or I'm not a practicing healthcare provider?
As we're waiting for that, the people to answer those questions, I was trying to find the ESMO guidelines. So one of the audience asked, we're talking about the NCCN guidelines. Yeah. How do these guidelines differ from the European guidelines? So I know, Rob, you're the current president of IGCS. Is there, I'm not aware of significant differences, but there's clearly differences between the ESMO guidelines and the NCCN guidelines.
Right. So one of the ones are ones that you know well, and that's the use of bevacizumab. So bevacizumab is still in many countries in Europe is only allowable for patients who have quote unquote high risk disease. So that would be a separate caveat into the use of bevacizumab. In addition, HRD testing is not uniformly situated over there, or at least it's not done. It can be done in a university lab. So it's those guidelines are less strictly defined, but they generally follow these guidelines in terms of decision making. So if you have credible evidence for HRD testing, you would basically follow the same algorithm.
Great. And you switch over the audience response. Somebody asked, can you use niraparib in HR proficient or HRD negative tumors after CRPR? Absolutely. That's what we're talking about pre-men every for 3 years. So absolutely, and something to consider in those patients that you have not started Bev or a switch maintenance strategy.
Okay, it looks like from the audience response that there are a lot of people that will follow the guidelines closely or very closely. And I think that's fair. I think that the guidelines, and Dave, you're, as a member of this committee, it's heartening to see that, that these are evidence-based decisions. Trying to make the best clarity, provide high clarity for patients given the wealth of data that we have, and we walked through a lot. We spent almost an hour on it, so hopefully that was informative to the audience. And with that, I'll close this section. Any last minute comments before we go over to the next one?
I think the only thing I would say is that I make this sort of joke when I'm presenting, is that things have really changed. When I was a fellow between 2004 and 2007, which is now a long time ago, and we operated on everyone, irrespective of how much tumor they had, and everyone got Taxol carbo. That's it.
Yeah.
That's all we thought about. And at the end of 6 cycles, you're like, okay, here we go. There was nothing else. And it's a very much more nuanced discussion and a kind of reconsideration of those decision points that you made throughout a patient's journey. So for example, I'll give you one short example. If you are one that doesn't like to use bevacizumab all the time, which is okay, I don't die on the sword for that. I will on PARP for BRCA though. But if you don't use that, okay. Yeah. And you start somebody with neoadjuvant chemotherapy, and she's just not responding well. And maybe she barely gets to the surgeon for surgery, or maybe she doesn't get to the surgeon for surgery. Her C125 is like creeping down. We know these women. We've met them. You're like, I'm worried about you. Cycle 3. I'm going to go back and add Bev.
Yeah.
Honestly. Unless there's a contraindication, that's someone I'm going to change my plan on.
Right.
I'm still going to send all the biomarkers. I'm still going to look for all the things, but I'm going to change my plan if that's okay with her. Some patients decline bevacizumab, and that's okay. It's shared decision making. But I don't think I just don't want you to think it's one decision point. You've made the decision. You can flex during it, because if she's not responding, that tumor has told you that she's not a prima patient. And so you can try and help her do a little bit better with bevacizumab, which works irrespective of homologous recombination status. It's not dependent on that. You get the same 30% reduction in the hazard of progression or death with Bev, irrespective of biomarker. So think about that, as you're seeing someone, again, if you get someone to no gross residual and they're on chemo, which is the best thing for a patient, you lose that clinical biomarker and you make the decisions based on the molecular biomarkers, which I fully support. But 50% of our patients get neoadjuvant, and you know who you're worried about, and
absolutely,
it's like cruising, and you're like, yes.
Yeah, I agree.
So think about that. Think about the shifting. It's a fluid
using all the tools. Yeah, using all the tools at your disposal. I think that's very good, and it's really the art of medicine. So paying attention to what's happening. That's a great closing part. So I'm not going to review everything we just did here in the closing, but I do think that we had an extensive discussion on the biomarker and how that can inform treatment. I think we covered it really well. Thank you for the discussion. But one thing we did not talk a lot about is immunotherapy, and I get this question all the time, right? We patients come in all the time. It's like, I want immune therapy because it works, and they obviously there's commercials we're inundated with commercials that basically show how wonderful patients do on immunotherapy. So, Katie, maybe you could walk us through, immunotherapy in ovarian cancer, a tough space, but one I think is really helpful to our audience to hear how this is played out.
Absolutely, I'm happy to. Unlike your talk, which was full of positive trials, it's not going to take me long. But you're absolutely right. Patients come in, and I'm a phase 1 trialist primarily, and patients still come in really interested in immunotherapy. And I was like, you've probably heard about Keytruda or Opdivo or Imfinzi, and they're like, yes. So we talk about the mechanism, and then we talk about the data, and that is illuminating to them, because the commercials are like the chance to live longer with lung cancer, so they come in with these expectations that you have to temper a little bit. But I don't think all is lost. But let's just look at what we've done so far, which is quite a bit. So this is monotherapy, really just PD-1, PD-L1 monoclonal antibodies. I didn't include CTLA-4, which may be honestly our best agent in this class, but the toxicities have been limiting here. We'll see what the next gen agents look like, but these are PO and PD-L1s. And Ursula Macelonis's work, which was at Keynote 100 at the bottom, is the largest study, 376. So this was really a biomarker seeking study looking at different levels of the CPS score, trying to figure out if you could predict who would benefit. And unfortunately, it just really didn't. We don't know the biomarker, if there is one, even in ovarian cancer. And in a recurrent setting, platinum resistant, this is no better than monotherapy cytotoxic chemotherapy with response rates that you can see, in the kind of 10 to 15% range. The Atezo study was a little bit of an outlier and interesting, but the responses were clear cell. And so we're still interested in that pullout. But again, it just speaks to the niche development of ovarian cancer. In high-grade serous, this is a 10 to 15% response rate at best, with no biomarker to really help us select who should be treated. Now, to the last slide that you saw, which was on genetic testing, just to emphasize that there are new guidelines out from ASCO that I would encourage you to take a look at. And for high-grade serous, these biomarkers that do predict response to immunotherapies, like MSI high is the one, less than 1%. You may find when here and again, and this is why we do next-gen sequencing to, save the one starfish on the beach, I would use it. But in endometrioid and mucinous, which has just no options, and to some extent clear cell, we do want to send those tumors off for testing, because you may get a hit there, and here immunotherapy may work. Those are rare subtypes. We're really talking about high-grade serous and what I'm going to talk to you about from here on out. But you want to send the next gen to look for it. Again, we're always looking for the needle in the haystack. Heck, you guys are all looking for NTRK, which I've never even seen on any NGS. And I said no, everyone never have had an NTRK fusion. Never, but I'm going to have one day. So if you're looking for NTRK and you think that's important, please look for MSI high and endometrioid ovarian cancer. But I digress. So interestingly, in the drug development world in ovarian cancer, unlike what you heard Rob talk about, which is we looked in recurrent disease, biomarker selected, monotherapy PARP, and it worked. 33% response rate, duration response was beautiful, got accelerated approvals, and we moved it on up the line. Here, we just got real excited kind of quickly, so we didn't really have a signal in the recurrent setting, but despite that, we moved it right up front. And, I'm being tongue in cheek about it now because I know the results, and in full disclosure, I'm the international PI for Imagine 50. So I was right on that bandwagon, beating the drum, that perhaps it didn't work in the platinum resistant setting because we had, exhausted T cells, and these patients' tumors had been exposed to so many things that we weren't going to see a signal unless we moved it to the front line. And so we did 2 very large frontline studies of immunotherapy with chemo. On the left, you see Javelin 100, which used avelumab. It's very much like GOG 218 that Dr. Coleman presented to you. And then on the right, you see Imagine 50, which is a 2-arm study of paclitaxel, carboplatin, bevacizumab, and bevacizumab maintenance versus the same with atezolizumab. There's subtle differences in the design, but in general, they're a little bit similar. They're more similar than different. Very exciting studies, but unfortunately entirely negative. And in fact, Javelin 100, they stopped early because the patients who received avelumab as compared to those who didn't actually look like they might be doing worse. Those are the patients in the yellow curve. And so that's interesting and a little disturbing. In Imagine 50, we just didn't see any clinically relevant benefit. It was 2 months of atezo versus bev. And so that was very disappointing. There were all sorts of exploratory subsets, and those are coming out. So it's a little bit embargoed, but you'll see the papers soon. But there's really, unfortunately, across these programs, not a big signal of who should get IO in the front line for now. But I'll show you some more data. So please don't do this. So what happened? 14 approvals in PARP over, since 2014. We've seen the same thing with immune checkpoint inhibitors in every other solid tumor except ovary. Like, what happened? And really, the bottom line is that unlike PARP, at baseline, these tumors have a very different immune microenvironment. It's probably very heterogeneous tumor to tumor, and they have a much lower expectation of monotherapy response, which you need to see. And there's a lot of things in the microenvironment. And I've listed like the tip of the tippity tip iceberg here. There's so many other things. TAMS may be a huge one in ovary. but Fas ligand has been one of the postulated tumor microenvironment factors that may impart resistance to immune therapy. But honestly, if that were the main feature, then imagine, sorry about that. I'm going to start using my hands and I advance. Imagine 50 should have been positive. Like if that's the main driver, then I should have been able to overcome that with VEGF inhibition. Yeah. So it's clearly not. And we really don't have biomarkers. The NCI put together a working group around immunotherapy and did an exhaustive search of biomarkers in gynecologic cancers. And I'm not quite sure it's been published yet, but the bottom line is there's really not a selection criteria to use. And so we just don't know really what to do yet with at least monotherapy use. And so
Katie, on that note, that we have some questions coming in with regards to biomarkers. So you alluded to NGS testing for rare tumors, endometrioid, mucinous, clear cell, right? Mm-hmm. So, but yeah, you also said PD-L1. I think you're just going to make this point, so I wanted to grab you before you moved on. So tell the audience here, what are the biomarkers that you check in a high-grade serous versus some of the others? Do you check PD-L1? Do you check MSI? Do you check MMR? Can you just tell us, the audience, just what are you doing in a typical high-grade serous versus some of the rare tumors?
So I'm not checking PD-L1 at all. It comes with, at our institution, we use a lot of foundation testing. And so we kind of get it automatically, but I don't even look at it because it's irrelevant. And actually imagine 50, Chip Landon is publishing this. He has presented it, so I can talk a little bit about it. Except for the very highest levels of PD-L1 expression as measured by that particular assay, which is entirely exploratory. There was absolutely no signal of patients who benefited from the addition of atezolizumab. And the same is true when you look at the avelumab data. So for high-grade serous, and probably for all the tumors, PD-L1 just isn't our marker. And we get, like I said, we send next-gen sequencing because that's how we get our loss of heterozygosity testing. Again, we use the foundation assay, and please don't take this as a affirmation of that. That's just what my institution uses. And then we get all the other stuff. We get microsatellite instability and other markers. So we are testing for that sort of indirectly because we get it on the next-gen panel. And we don't have to be directive about it. If I had to be directive about it, I would only be checking that really for my rarer tumors. But as it is, because of how, at least in the US, how accessible NGS is, we kind of get it on everybody.
Yeah, and one thing, to add to that, on this slide that you're showing, you can see that the TMB is obviously, immune checkpoint inhibitors are also approved for patients that have high TMB. The ovarian cancer is a disease that's defined, a high-grade serous, defined by copy number alteration and not by mutational load. And right. You can see here, it's a very nice graphic showing where ovarian cancer sits with a mutational count somewhere on the order of 2 to 3 mutations per megabase. So one of the major reasons it doesn't fit into what you see on TV is that the tumor is not driven that way. Right. So we're constantly trying to figure out a way to overcome these barriers. And I think you hit it on one, you mentioned it quickly, but I think it's really relevant. And that's the tumor associated macrophages, right. Which can be actually enriched under the use of bevacizumab, especially the type of macrophages we see there. So yeah, there's much more work. We haven't cracked it yet. We certainly have not given up. But what you said about common use of immune checkpoint inhibitors, use of PD-L1 for trying to determine who those patients are, or even the mutational load, is just not there.
Right.
So genomic instability test of some sort, Myriad, right. Foundation, we've mentioned, right? Yes. We talked about extended germline testing for all patients. And in the rare tumors, clear cell, endometrioid, and mucinous, consider MMR or MSI, and potentially next generation sequencing, looking for some of these other rare tumors. That is not HRD testing, though. That is a different testing modality, looking a completely different set of in other rare tumors. So I just want to make sure we make that point with regards to the differences in what we're talking about, HRD versus other options of treatment, particularly in rare tumors.
Yeah, I think that I wish we could talk about rare tumors. We're kind of running out of time, but I think probably most of the folks on this call are doing this already. NGS is so prevalent, but you will find you'll hit, especially in patients with mucinous, which is only 5% of our cancers, but they don't respond to chemotherapy, and they tend to have a very difficult course. But, if you hit on an ERBB2 amplification,
or a RAS mutation,
or RAS now, when you can target RAS now, it's even getting better and better. And triage those patients to trials, you actually can find things that will help them. Clear cell the same. And then endometrioid, you can hit upon these MSI high folks, tumors, and then they really respond beautifully. So again, it's not everyone, it's not common, but you do hit on these really actionable findings for them, much more than high-grade serous, much more.
Yeah.
So I would encourage you to not get nihilistic about NGS and ovary, because the rare tumors really need you to continue to look. And so on this last slide, I just said, it's been kind of problematic and negative, and lots of the reasons we thought it wouldn't work, are probably not the real reasons. That monotherapy chemo or monotherapy immune checkpoints have been incredibly efficacious. So the question is, can you combine them? And there's tons of combinations. Actually, all of us run like hours of calls today talking about combinations in cervical cancer today. But we're talking about ovary here. And so there's been a lot of combinations trying to synergize with immune checkpoint inhibitors, for most patients, they play well in the sandbox. Not all, of course, there's toxicity, but the PARP inhibitor combinations really have kind of beautiful preclinical rationale. The first, which is probably not true, but we all believed it for a while, is that patients who had this inherent vulnerability to how their tumors repair their DNA, so homologous recombination deficiency or other means by which their tumor's DNA just struggled to fix mutations, there would be more neoantigens, and that would lead to this robust immune response. And I think we all can remember seeing the presentation at ASCO, like in 2015 or 16 in BRCA models, and we're like, well, this is the group of patients who are going to respond to immune checkpoint inhibitors because they have all these neoantigens. And that was shown preclinically, but it did not pan out clinically, interestingly. And that happens. So that theory may be true, but it doesn't explain, it certainly doesn't predict who's going to respond to monotherapy immune checkpoint inhibitors, and probably not combinations either, I'll tell you. But maybe the more correct hypothesis is that when you do have these tumors that have an inherent vulnerability, you do have damaged DNA, which will transfer from the nucleus to the cytoplasm. So you get this cytosolic DNA, and that's what activates your stimulators of interferon genes, or the STING pathway. And the STING pathway triggers this innate immune response. And so that may be truly synergistic. And that's also been shown by many of our colleagues in beautiful preclinical work. Now, unfortunately, is not panned out clinically. And these two works were done by two people I actually respect hugely in the field, Panos Konstantinopoulos and Dr. Joyce Liu at Dana-Farber. Both of them are at Dana-Farber. Panos ran Topazio, which is niraparib and pembro, and Joyce ran Opal, which is a multi-arm study, but this particular arm was niraparib, dostarlimab, and bevacizumab, so a PARP, an IO, and Bev. And then Topazio was a PARP and IO, of course, pembro. And in platinum-resistant recurrent disease, both of these, similar criteria. And really the response rates are the same. And when you think about drug development in the resistant setting, and we have benchmarks for sort of what's a signal that makes us say, well, this is something, I'm going to take it forward into a bigger study. This is about half what we would want. So really very well done studies with beautiful translational work that they've done, but not super exciting, to be honest. And there were patients with BRCA on these. You would have expected them to do amazing, and they just didn't. So back to the drawing board with that. And it may come down again to this idea, just like I mentioned at the beginning, that we're testing these immune checkpoint inhibitors in tumors that are already resistant to platinum. And there's something fundamentally that changes potentially with the tumor microenvironment that contributes to that resistance. And so maybe if we looked at it earlier on, it would help, the same theory we had with moving things to the front line. And so some I would just hesitate to overinterpret this, but it is interesting. We are kind of excited about it. This is Mediola. So Mediola was done in BRCA wild type, but platinum sensitive, PARP naive, all those things. And in maroon, it's a triplet, just like Opal, what Dr. Liu did. Olaparib, here it's just different company, PARP IO Bev, Olaparib Durva Bev, versus the doublet, PARP Bev, or PARP IO, PARP Durva. And these are all platinum sensitive, and then they were stratified by genomic instability score, by the Myriad assay, positive meaning HRD, negative meaning HRP, and then unknown. And interestingly here, these are very small numbers, but look at the waterfall plot in the platinum sensitive group. These are both platinum sensitive populations, but look at the maroon group. Only 2 patients didn't have some tumor shrinkage. And the response rate amongst those HRD was 100%, 10 of 10 patients. Now you'd expect that with a PARP in an HRD population, maybe not 100%, but pretty high. But in the HRP group, this genomic instability score negative, now remember this is BRCA wild type, the response is 75%. And you might say, well, that's just driven by the PARP, right? They're platinum sensitive. And you told me earlier that platinum sensitivity is the key biomarker for response to PARP. Well, I did tell you that, but look at the doublet. Olaparib Durva at 17%, just like the other study. So this looks very different when you look at the 2 groups, and gives us some hope that perhaps one of these frontline studies will be positive. So these are the 4 maturing frontline studies, 3 of whom have Taxol carbo with or without Bev. Actually, one of them requires Bev, the other 2 with or without Bev, and Bev maintenance with an IO with a PARP. And so you're going to have triplet maintenance tested potentially in 3 of these studies in a vast majority of the patients. Athena is a pure switch maintenance PARP versus PARP IO, and that will probably result first. We'll see. But the other 3 have a little longer to go. And so if that Mediola signal is real, we may maybe marginally move the needle in HRD, but we may massively move the needle in the 50% of patients who are HRP. And that would change the whole hazard ratio of the trial. So I'm interested in that and excited, tentatively excited. I do lead first in the US, so I'm a little biased, just so you know that. I'm trying not to like oversell it. But I think these have to mature. So before we use another immune checkpoint inhibitor in the front line in any way, shape, or form, these guys have got to result and kind of give us some sense of if there's any signal here or not with PARP. This is going to be the proof in the pudding for big trials. So it's kind of an exciting time. Probably the next 2 years will be interesting. So with that, I think I turn it back to you.
Yeah. Before we go back, let me just go back to that previous slide. One of the things that to emphasize here is that each of these trials, although they have a kind of a common theme of triplet therapy, they do have different weighted patient populations.
Yeah.
So, and I think you mentioned this because in the genomics instability, or the stable cohort, the HRD test negative patient populations, we're going to get a lot of information to help either confirm or refute what you said in that observational trial in Mediola. So I agree. I think, again, as we try to get excited about immunotherapy, find someplace where it works. These trials will help us inform that. We'll have thousands of patients here through these trials to be able to make that decision. So stay tuned and let's see what we get.
So with last 5 minutes here, for the last 5 minutes, this is not a loaded question at all. Are the PARP, and we got asked 2 different ways, are the PARP, VEGF, and now somebody's added immune checkpoint inhibitors interchangeable? So why don't, Rob, you start off with, where are you using the different PARP? Are you using different VEGF? And we just said we're not going to use IO in ovarian cancer, so maybe we should just stick with the PARP and VEGF.
So VEGF inhibitors, come in several varieties. The most common of which are the tyrosine kinase inhibitors and the antibodies. So, And of course, now there's biosimilars available for the antibodies that are now approved in the United States. So in general, and of course, we don't have the head-to-head competition, but in general, it appears from the data from the studies that have like over 12 that have used a TKI versus a trial in a similar patient population that have used an antibody, particularly bevacizumab, that the treatment effect seems to be larger with the antibody as opposed to the tyrosine kinase inhibitor. And the toxicity profiles are different because most of the TKIs have multiple hits. So they're dirty kinase inhibitors that do affect more than one target, which initially we thought was going to be beneficial for patients because it attacks other elements within the tumor microenvironment, such as PDGFR and FGFR. But we haven't really seen a dramatic effect. And of course, there are none that are approved in the frontline setting. So I think that for right now, it appears as though biosimilar bevacizumab and bevacizumab would be interchangeable. And in some situations, some healthcare systems, that's already being done.
Yep.
So I think that's okay. With respect to the PARPs, we get
back. Let me throw this one to Katie. Katie, Katie, how are you making differences? How are you differentiating the PARPs?
Well, that's a good question. So in the front line, you only have niraparib and olaparib. So far, we'll wait to see if Athena brings rucaparib to the front line. Mm-hmm. I really differentiate it honestly based on the indication right now. So for my patients where I said I like bevacizumab, but I don't use it in everyone. And so if I have somebody, I have a lot of patients with terrible hypertension. It's just there are contraindications and they respond beautifully to chemo. I'm going to put them on niraparib because that's my indication for everyone who's not BRCA. So I have to be. My office is very smart at using niraparib and watching the weekly labs and watching the platelets. And I have a team, very lucky. And then olaparib, I use for anyone that's HRD positive with Bev so that I can use the Paula regimen, which I actually like a lot, especially in BRCA wild type HRD. That's my favorite regimen. I will be biased there and tell you that. And then in all my BRCA associated tumors, I'm probably more likely.
There you are.
Katie just fell off her chair.
She got those hands going. She's changing slides. She's moving the camera.
I'm in a hotel room and I have my computer balanced on an ice bucket. So I'm like, I made it 2 minutes from the end.
It's melting
up, but here I am. So there's no ice in the bucket, just so you know that. So I use it that way, and then I also make decisions just based on perceived patient tolerance. I think it's just real world patients. Some patients come in, they're like, I can't take oral medication. I've always struggled to swallow pills. And they're not lying to you. They really do struggle. And so for them, niraparib is probably an easier medicine to use. It's once a day and the pills are quite small. And most patients start with 2 rather than 3. Some patients have terrible hypertension and I won't use niraparib because you can have hypertension there. So I use both. I think they're both very good agents. They're very active. I don't think there's no difference in efficacy in my mind between them. So it's very patient driven.
Well, we had a couple more questions, but I see we're up at the hour. So Rob, I'll turn over to you to bring us home, buddy.
Okay. Well, great. Well, thank you so much, Dave. And thank you for monitoring those questions. I just wanted to, first thank everybody who joined tonight and to my 2 friends who helped to walk us through these slides. I think I'm just going to show these summaries here that, I think we have convinced ourselves that, Taxol carboplatin still is a standard baseline for us, and that we have definitely reached a kind of a ceiling with that without the addition of our biologics. We've seen measurable impact from bevacizumab and from our better use of molecular annotation of these tumors, either through HRD testing and through BRCA1 2 status in the tumor and in the germline. I think you heard from all 3 of us about how we approach that in the frontline setting. It's very important to get that information. And as Katie closed us out, demonstrating that although we've not been able to find the right place for immunotherapy, the current crop of trials are going to be very informative in very clearly defined populations as to whether or not these particular drugs actually have merit. So stay tuned to that particular for those results to come. So just let me just read off these SMART goals. I had to actually write this on my board. I think I still have it on my board of what SMART stands for. These are specific, measurable, attainable, relevant, and timely. These are goals that I often use on my teams as well for different objectives. But our SMART goals for today were that we should order early tumor genetic testing to determine the BRCA and HRD status for all of our cancers. We should adhere to the treatment guidelines that incorporate these biological features, MSI or MMR and TMB, to inform treatment. And again, and all three of us on this, I know I speak for them, that we recommend that if you have the opportunity to participate, have your patient participate on a clinical trial, that you do so. And and these trials that we just mentioned are really there only because we have had the generous participation of our patients who have participated on these trials, and they will provide us information about PARP inhibitors and immune checkpoint inhibitors. So, we are open to answer questions after the show. Here is your resource for doing that, and hopefully you were able to take advantage of not only the CME credit, but also the slides. And we hope that you will have those available to get those from us or get them from the platform. Again, thanks, Dr. Moore and Dr. O'Malley. It was great to share the stage with you guys. And thank you to all the audience for participating and providing those questions. And have a great night.
Thank you.